Good afternoon, everyone. I'm excited to have you join us for our 11th quarterly expert roundtable focused on value-based care. Specifically, does it work? So let me set the stage before we jump in. Value-based care represents a paradigm shift in our healthcare delivery system, focused on achieving the best possible outcomes while optimizing the use of resources. It's not a new concept. In fact, early models first entered in the early 90s, but even the most studied programs have mixed results. There's certainly been opportunities created as a result of the promise of value-based care, and yet we still haven't figured out really an easy button to pay for it. Today, the majority of models and data are centered around Medicare Advantage populations and primary care, largely focused on this middle section of payment models. In fact, Medicare payments today, about 25% of those Medicare payments are paid through capitated payments, but this is unique. We're seeing continued investment in primary care models. Last year, Humana and Welsh Carson announced their reinvestment of $1.2 billion in CenterWell. And CMS announced just last week the Making Care primary model, which is focused on enhancing access and quality of primary care, particularly for rural and underserved communities. The research suggests that about 15 to 20% of market share will shift from traditional fee-for-service to fee-for-value models in primary care by 2030, creating significant tailwinds for further investment, which we're really excited about. But while adoption today is largely focused on primary care, designing value-based care models for specialty care is gaining interest. And I would say episodic conditions like ortho and maternity care are really ripe for these models. But we're seeing an interest and uptake on the chronic condition side as well, with models in nephrology and oncology, which we'll dive into later with our speakers. And briefly on full risk models, today only a small percentage of practices actually operate in full risk models. The most recognizable being Iora, which is a Flare Capital portfolio company, which we sold to One Medical for $2 billion in 2021, and Oak Street, to name two. These models all require deep knowledge of the underlying metrics around claims, MLR. They require a robust analytics engine that is both accurate and clinical, improved care team communication, and highly integrated clinical operations. Needless to say, very complex models, and no doubt they're high in quality, but these models can be quite costly. We can't ignore that performance of value-based care models more broadly is mixed. Recent reports on the ACO performance indicated that nearly 30% of the groups that participated in CMS's direct contracting program actually experienced net savings losses. While approximately 60% of all healthcare payments have at least some linkage to quality and value, CMS is pushing for better and has set a goal for 100% of Medicare payments be value-based care by 2030, and the majority of Medicaid and commercial payments by 2025. You can argue it may not all add up. There's mixed results, and we're doubling down. We'll hear from the experts today on this topic. So while progress is encouraging, increased participation from other payers will be needed to unlock the full market potential, and implementation is not without its challenges. We're excited to dig into the challenges of moving from a fee-for-service world to a fee-for-value world and learn from the experts on how to successfully solve for both quality and costs. So with that, I'm excited to be joined by a group of senior operating executives and experienced entrepreneurs who will share their perspectives on where we are today in the value-based care hype cycle. Our panelists include Dr. Will Shrank. He is the former Chief Medical Officer at Humana and current venture partner at Andreessen Horowitz. Corbin Petro, the co-founder and CEO at Eleanor Health and former executive at Benevera and Mass Health. Dr. Joe Kimura, the Chief Medical Officer at Somatus, a Flare Capital portfolio company and former executive at Atrius Health. Dr. Seth Glickman, the Chief Medical Officer at Inbound Health, a Flare Capital portfolio company and former executive at Blue Shield, California, Intermountain Healthcare, and UNC. Dr. Emily Maxson, she is the Chief Medical Officer at Aledade, and Veeral Desai, the Chief Strategy and Development Officer at Agilon Health and former executive at Vantage Oncology. We'll be hosting 3 discussions over the next hour. The first is a fireside chat with Will Shrank, facilitated by my partner, Michael Greeley, to dig deeper into Humana's role as a trailblazer in value-based care. Then we'll shift to understanding the white spaces by talking to startup executives Corbin Petro, Seth Glickman, and Joe Kimura, and myself. And finally, I'll invite my partner, Dan Gebermedin, to dig into how providers and technology can be used to advance the value-based care shift with a conversation with Veeral Desai and Emily Maxson. So with that, I'll invite my partner, Michael Greeley, to the stage for a conversation with Will Shrank. Michael, welcome to the group.
Thank you so much, Margaret. And as Will comes to the stage, Will, that was realistic, but perhaps sobering overview that Margaret just provided. Will is a great friend of mine. We have had the pleasure of serving on a board, Cohere Health, one of our portfolio companies. And Will has sat really at the turnstile of this whole phenomenon, principally at UPMC and Humana. We only have 15 minutes, but maybe could you just take a few seconds and just more properly introduce yourself, provide some context?
I think you did a great job, and any additional introduction will just demonstrate the extent to which I've had a hard time holding down a job. The one other place I did spend a bunch of time thinking about these issues is when the Innovation Center first started. I led the evaluation group at the Innovation Center, helped stand up a bunch of the programs that I expect our team will be talking about today.
Yeah. And so with that, Will, just given your history with this level of innovation, characterize where you think we are. If this were a baseball game, what inning are we in?
I think maybe fourth, fifth. We're not early innings anymore. I think we have a lot of conviction now that providers will engage in, will transform their practices in, and can be successful in value-based arrangements. I think we have seen a meaningful change over the last 11 years. And there's some that would say only a small proportion of those models that have been tested at the Innovation Center have been certified and have met criteria for certification. I think that's the wrong measure. If you had told us 11 years ago that the health system would look as different today as it does from 11 years ago, I don't think any of us, we could have hoped, but it's pretty amazing the amount of change we've seen.
Yeah. And do you think there was misplaced or lofty expectations around the cost impact? You'd see a cost impact before potentially an outcomes impact. And some of the recent data is nuanced, mixed.
Yeah, I think the MSSP program is the best example, the best sort of area to look at results to get a good sense of the evolution of performance. At the outset, the MSSP program didn't save a lot of money. The last year that the results were shared was 21, and the MSSP program saved $1.6 billion for CMS. That didn't happen in a year. It didn't happen in 2 years. It takes a while for providers to figure out how to provide care better. And the expectations around transforming practice and then seeing health outcomes changes was totally unrealistic. I think there was also a need at the outset for CMMI, for CMS, for Sylvia Burwell, for folks to create a sense of inevitability and set those lofty aspirations, but they were unrealistic. And I think right now we're just starting to see the true benefits of those.
Yeah, and so you don't declare victory in the fourth inning of a baseball game. So what is the data that you're looking at that gives you that confidence?
I think MSSP is a great place to look. If you look at the bundles, the outcomes from the bundles is better quality and savings. Just the savings hasn't been to Medicare. There've been a reduction in costs. It just hasn't created savings for Medicare. If you're creating better quality at lower cost and the providers are getting reimbursed for that, I don't think that's a loss. The most important thing to notice is that in the MSSP program, the place you're seeing the greatest success is not in health system-led ACOs. It's more in the primary care-led ACOs.
Yeah.
And the place that you're seeing the greatest results, and I've had the good fortune to work in a couple of these organizations where I've been really close to the work, is Medicare Advantage, where there's just a much deeper relationship between payer and primary care. And that's where the energy and emphasis around value-based payment is really directed. And that's where we're seeing unquestionably great results.
Yeah, and you were obviously a key architect in the center and a lot of the initiatives that Humana was driving. Any insights from that you might offer the audience?
Yeah, I think what's different about the Medicare Advantage setting is that you just have tons more flexibility. So if you have a primary care, if the payer is an arrangement with a primary care organization, and then that primary care organization has the flexibility to negotiate bundles underneath, to work with specialists in progressive ways underneath, you have a total cost of care model that engages specialists as well. And that's, I think, really been missing. I think you've had these sort of bundled programs in traditional Medicare, and you've had total cost of care, MSSP programs, but there's a lack of real integration. And in Medicare Advantage, you do have a much richer opportunity to create that integration.
Yeah. And not to torture the analogy, but in baseball, there are winners and losers. As you apply that to the value-based care space, who are the losers? Obviously the winners are probably evident, but who are the losers in this?
I think I've been somewhat disappointed that health systems haven't really moved as quickly as we would have liked. I would have hoped that health systems would really transform the way they do their business in a much more intentional way. And I think because of the way that health systems are paid, and a lot of them make a lot of their margin on commercial business, it's hard to really, truly transform the clinical model.
Yeah, and
as a result, if the health systems aren't going there, then I think a big chunk of the healthcare ecosystem is going to flail in this environment.
Yeah, the economics are obviously stacked against arguably this phenomenon. Do you think there's a generational issue with clinicians? Do you think clinicians are embracing it as much as we'd hoped?
I feel like I probably had a bit of a skewed perspective because of where I've worked. I'm sure there is a generational component in that you have to rely heavily on data and analytics and your ability to risk stratify and your ability. Frankly, you have to give up a lot of autonomy to work in a team in order to be successful. Good value-based care requires team-based approaches, and it's just a meaningful difference in philosophy and how practices work.
Yeah, and you've obviously spent a lot of time in the primary care space. Comment, if you would, on some of the subspecialties. Which areas do you think are particularly poised for this? And which areas will never get there?
Well, I don't think it's an issue of anyone that's not going to get there. I think specialists are going to go in one of two directions. Either specialists really focus on procedures or episodes of care and are going to move towards bundles. Or they're going to say, I believe I can take responsibility for a portion of the population and manage all the specialty care for that group. I think virtually every type of specialist can fit in one or the other of those categories, whether it's a subcap or a bundle, in a setting where you have a total cost of care arrangement and you're partnering underneath with those, whether it's primary care or an integrated network that's caring for a population. I don't think anyone should be left out. We can make this work for everybody.
Yeah, and you and I alluded to at the outset, served on the Cohere Health Board, which is, we think, a rocket ship reinventing prior authorization. You've thought deeply about the infrastructure, the tech infrastructure. What are some of your observations around some of the emerging solutions that will drive this transition?
It's just been amazing how much the pandemic really accelerated a lot of these concepts that we'd all been talking about, but it took a crisis to really change practice. Virtual care is, again, it's happening at scale. Care in the home is going to be the norm. I think we've been talking about it for a while, and now we know that's true. And I think sort of the technology that allows and supports better proactive care, better identification of those who are at risk, allowing better connectivity and engagement with patients while they're at home, and that delivers that care at home. There's a whole host of technologies and new enablers that are just going to play a very central role.
Yeah. I want to get to your role as a venture capitalist, but as profound as an accelerant as COVID, the onset of COVID was, we now are in arguably a historically poor financing environment. And so our industry, I'm a little bit of a broken record, has been funding kind of 350 to 400 companies a year. The last couple of years, it spiked to several hundred. Speculate on what that landscape looks like over the next 3 to 5 years as it begins to consolidate, and the impact on maybe value-based care. We have dozens and dozens of virtual care providers, some emerging winners, some are still struggling to get traction. What does that landscape to you look like over the next 3 to 5 years?
I think you're far better to answer this question than me, but I'll take a stab at it. The consolidation, I think, is generally going to allow a faster transition. I think that the fragmentation of the marketplace has been complicated for incumbents. And I think incumbents have largely have so many relationships with so many vendors that they're not integrated, and it frankly can lead to excess or additional fragmentation. I think this kind of consolidation and having some winners and those winners being more prepared for scale is going to allow the marketplace to move faster. I think it's unfortunate because I know there's some great ideas that probably got beaten up over the last year or two and maybe won't succeed. But in the long run, I think this is all going to accelerate change.
And then, so how would you counsel the self-insured employer that's looking at that landscape? Do they wait? Do they jump in? Do they take vendor risk? How do they think about that?
Yeah, it's interesting because self-insured employers have so much power. They have so much influence if they have a decent amount of employees. They also, if the focus is really just to minimize cost, they know how to do that already.
Yeah.
It's really a willingness to say, I want to jump in and shake things up and make care better for my employees. And I try to, frankly, have an impact on the marketplace in general. If they do, the more employers lead, that's the central challenge to our movement to value-based care is the overwhelming reliance of health systems on commercial rates. And that is a massive barrier to truly transforming care delivery. And the depth of relationships that employers who have local scale, local market power could drive, I think that's probably the last thing that needs to fall and really move things towards value-based care faster.
Yeah. And you touched on this notion of scale, and consolidation may lead to scale. In an environment where capital is expensive, hard to access, the notion of scale in some of these models may be somewhat elusive if you need several $100 million of capital to get to scale. How, I'm transitioning a little bit into your role as an investor now, how do you think about which models will be successful if they can't access that level of capital? How do you think about that notion of scale?
I think that's challenging. I think you have to be really thoughtful about who your partners are and finding strategic partners that have skin in the game and feel invested in your success.
Yeah,
I think that it's going to require. I think it's a model that you, Michael Grilli, have employed very successfully over the years. That finding the right kinds of partners that a rising tide is going to lift all the ship.
Yeah. And is it clear, this notion of scale, however we define it, that at that point, it creates economic value? We can see cost savings, we can see impact on outcomes, but is it clear to you that these companies will create economic value?
Oh, absolutely. I think
as measured in free cash flow, attractive gross margins, they'll be self-sustaining.
Look, I think large incumbents can't build what one can build in a venture-backed environment. No question, full stop. And incumbents have swings of willingness to invest. And there's no question that the overwhelming proportion of true innovation is going to come from outside of incumbents.
Yeah.
And once you've got something that offers true value in the management of a population, you're going to get paid for it. And particularly in an environment where there's so much emphasis and energy around delivering better care at lower cost. I have no doubt on that.
Yeah. Just in the last 2 minutes, obviously, I was sad to see that you weren't joining our firm, but delighted that you were joining such a terrific platform. How are you spending your time now as an investor? What are you excited about?
Yeah.
What's our next deal together?
Well, let's talk about the last part. I think one thing that's been really fun for me is that the working with portfolio companies is like I get more energy out of those relationships. Dealing with entrepreneurs, when entrepreneurs were selling to me, it felt a little different. There was a little less humility maybe, and a little more emphasis on having all the answers. But the truth is, these are some of the smartest, most engaging, most passionate folks that are really trying to make a difference and do so in a way that can happen quickly. And being on their team and helping them think about it is really fun.
Maybe last question, just you don't need to give me a specific name, but what's like your hottest idea right now? Are you doing something in ChatGPT?
Oh, obviously Andreessen Horowitz has a strong presence in the AI space. Yeah. And it's just amazing to see what innovation's possible with these large language models. I can't fathom how rapidly that's going to help us accelerate some of these changes.
Yeah. Well, I am immensely grateful for your time. I'm eager to do an investment with you.
No
I'm going
fun.
to turn it over to my colleague, Margaret Malone, and a terrific group of hopefully really emerging winners in the category. Will, thank you so much.
It's a pleasure. Anytime. Great to
You're
see
the
you.
best. You're the best.
You're the best.
Thanks, Michael and Will. That was a great discussion. Really excited to spend some time on innovation and the areas of white spaces. Hey, Corbin. We'll give a moment for our panelists to join. Hey, Joe. We're really looking forward to, I think we've got a lot to chew on from that discussion. Hey, Seth. So maybe before we jump into some of the questions, would love to hear from each of you a little bit about your background, what you're building, and maybe we can start with you, Corbin.
Great. Thanks for having me. I guess I'll take a tip from Will and keep it fairly short, but co-founder and CEO of Eleanor Health. I've spent my career in healthcare, both in the public sector as well as the private sector, really focused on underserved populations. Unique payment models is an area of passion for me, and delivering healthcare in new ways, integrating technology and data. I founded Eleanor Health in 2019 after watching opioid and alcohol use impact people's health more broadly in the last company that I ran, as well as in my own family. And so when you think about addiction, it affects 40 million Americans. It's largely been treated in fragmented, uncoordinated, non-evidence-based models that really treat it as a moral failing. And our goal really at Eleanor is to treat it as a chronic condition longitudinally, and we do so through partnerships with payers in various value-based ways. So excited to have this conversation, and I'll hand it back.
Thanks, Corbin. Joe, over to you.
Yeah, no, it's fabulous. So I'm Joe Kimura. I served as Chief Medical Officer here at Somatus. We're one of the nation's largest and probably most effective, if I can say, value-based care, kidney care company out there. Before that, I was at a lot of value-based multi-specialty sort of groups. I was at Atrius Health and Harvard Vanguard, Chief Medical Officer there for 7 years before moving over here to Somatus last summer. I think in the kidney care space, we'll get into this. We're started in 2016 by Dr. Akina Okezi. We're now caring for over 160,000 patients in 36 states. And really, this is an opportunity. I know Will's talking a little bit about what those places are in medicine, and they are a plethora of them. In the CKD and ESKD space, there is so much waste that's happening clinically and the opportunity to make things better for patients and the system as a whole. Super excited to be part of the conversation. Thanks for having me.
Thanks, Joe. And Seth.
Yeah, thanks, Margaret. I wanted to just say thank you to you for organizing this event and the FLAIR team for supporting this work on an ongoing basis. So I'm Seth Glickman. I'm the founding Chief Medical Officer at Inbound Health. I joined Inbound Health approximately a month ago, and Inbound is a technology and services company that enables provider organizations to provide hospital and SNF at home services in a manner that's highly safe, cost effective, and very scalable. And really excited to be part of the team and the journey with Inbound Health and FLAIR. And then just a few snippets about my background. I've been a physician executive and entrepreneur for 20 plus years, spent most of my time in leadership roles on the provider side, and also spent time on the payer side. I was the chief medical officer of both Intermountain Healthcare and Blue Shield of California before joining Inbound.
Awesome. Thank you all for the backgrounds. And I'm really excited for this conversation. I think we'll dig into a couple of topics. We'll probably build a little bit on Will's comments as well. But I think we'll probably touch on a couple of key topics of specialty care, implementing these models. I would love to get the technology angle here as well. And then really what's required to build a company in this space. A lot to tackle in a short amount of time, so we'll jump right in. So one of the first areas I wanted to dig into is really around data and the use of data to design value-based care models. I think outcomes data is probably notoriously difficult to measure, particularly for behavioral health. And so Corbin, I wanted to start with you and get your perspective on where are we today in standardizing clinical outcomes in behavioral health, and how has this kind of impacted or influenced the way that you've gone about designing value-based care models at Eleanor?
Yeah, so I wish I could say that we're at a place where outcomes are standardized. A good number of outcomes in behavioral health are quantitative and can be tracked over time so that you can actually show improvement, but many of those are member reported. So PHQ-9 and the GAD-7, Recovery Capital, a lot of different member reported tools that really track and show improvement in quality. a lot of the outcomes that have historically been used around retention or negative urine drug screens in the recovery space, you can either cook the books or it incentivizes you to cherry pick certain patient populations. The one area that we've had the most success in tracking and obviously getting payer adoption of various risk models is tracking to total cost of care. So we do a lot to measure ED and inpatient reductions. We do matched cohort analysis, which is really important for a progressive chronic condition, is to make sure that you're matching to an unmanaged cohort to show the impact that you're having. So that's really where we've seen the most. Obviously, we're leading in the space, creating these value-based models. And so we have to come to the table with our perspective, a model that works, have to put some fees and other components at risk to really get payers to have interest. And that total cost of care is obviously always going to be really important to payers and ends up being the lever that helps to move them forward.
That's great. And how do you think about kind of the time that's required to prove total cost of care and balancing that with the priorities of building a startup and building the car as you're driving it in some ways? But curious kind of how you've navigated that.
Yeah, I mean, I think in total cost of care, you think about a health plan's perspective, and I ran a health plan in my last role, everything's on a 1-year cycle, and then you have your claims run out. And so that's the most clean way to do it, is to have 1 year plus a run out, because it shows seasonality and the various factors that go up and down. You can also show it if we were able to show impact in a shorter period of time, because often our patient population is progressing very quickly in their disease state. And so by stabilizing, you can see some immediate cost savings. But I think depending on the type of company or condition, that sort of year plus, I hate to say that because I know people are always looking for more, but there are a lot of leading indicators along the way that can help to drive early partnerships with payers, which I think those early flyers that payers take on companies are really important to prove out the model. And there are a lot of payers that have specific budgets to do that. And so I think that helps just the innovation economy.
Joe, I see a lot of head nodding. I'm curious kind of your perspectives on that as well.
Yeah, no, I think that 1 year cycle is clinically the bane of everything, right? Because not only on the financial accountability, but clinical quality right now is bootstrapped to that as well. And so you have a lot of these measures that are currently being used that are the accountability measures of a lot of these value-based care programs that, again, look at 12-month sort of timeframes overall. And particularly for chronic conditions and longitudinal care, sometimes that's actually not clinically a super fair way of thinking about it, but it is what it is. And so these are the rules that I think we're all playing with, and we've got to figure out how to optimize. But I think there are opportunities to say, we know there are short-term outcomes that can be capturable. We know that there is economic value to be created in that sort of months time frame that doesn't take 3 to 5 years. As a primary care doc, like, we always like to think about the long-term, the more durable, longitudinal sort of types of things we'd like to work on from a preventative perspective. But realistically, I think you have to marry the two of them and figure out how to be working on both pathways at the same time.
Yeah, that's great. Switching gears slightly, and I think you kind of touched on a little bit there, Joe, and I think Will touched on it earlier in the conversation, is just sometimes challenges to operationalize these models as physicians, working with physician networks. And both you, Joe, and Seth have worked kind of intimately as a physician yourselves and also with these groups. I'm curious, from your perspectives, what are some of the, I'd say, must-haves in order to implement value-based care programs within the provider setting? Maybe, Seth, I'll let you kick us off.
Yeah, sure. It's an important question. I'd say 3 must-haves really come to mind for me. One is having really strong physician leadership and governance. And that doesn't mean a physician needs to run every company, but the physician leader at the top of the organization, I think, needs to have clout, and there needs to be a formal structure in place that this important strategic and operational decisions are really provider-led. I'd say 2, and it's something that Will hit on, is that value-based care is increasingly a team sport. This is not something any one physician can do successfully alone. And so building structures, both operationally and financially, to support team-based care is important. And then the third thing I would say is a must-have is you need to have really strong payer-provider partnerships, which is why I enjoyed working as a leader in an IDN at Intermountain. And they're hard to find, but they really need to be grounded in common values and a commitment to affordability and really transforming healthcare. And I think that's a critical ingredient as well.
Great. Joe, would you add anything to add or disagree?
No, absolutely. I think that's in my mind. I think about, and Seth was mentioning these, like that clinical model is key. I think physician leadership, clinician leadership is going to be important, particularly because I think you are asking the clinical folks to be practicing in this prevention is the ultimate form of treatment kind of mentality. Be proactive, don't wait and react. We always joked around and said, it's one thing to provide the world's best hip replacement care. It's the other thing to actually prevent the patient from falling in the first place, right? Which is better for everyone involved and less costly. So I think that's an important sort of side, team-based care, population health management, patient engagement activation, whole chunk of stuff that you need to be thinking about. How do you transform that culture? I think the financial part is there's a lot there, right? In my mind, I think about all the stuff that Will was mentioning around all the actuarial expertise, trends, attribution models, and then all the measurement stuff that happens, right? The HEDIS, the STARS, you name it. There's all these systems there that I think you need to get familiarized with to be able to demonstrate that you're not withholding care, you're doing great work as you're reducing those costs. But at the end of it, and I'd love to hear more about Seth's world in this place, right? That informatics foundation is critical, right? Because it is all about not waiting for things to happen. It's anticipating things. And guess what? In population health, it's a different kind of volume. The number needed to treat is large to prevent a bunch of things. So you need to be able to pick who in that population is going to benefit most and do that quickly and efficiently, or else you're going to have an infrastructure that's far too big to be able to sustain. So.
Yeah, that's great. And maybe doubling down on that, curious if we think about technology and how we can use technology to enable that scale and the kind of predictive elements of that. I'm curious your perspectives on what are the kind of key technology enablers for value-based care. And Corbin, I'd be curious your perspective, especially given behavioral health is perhaps hard populations to engage with, and perhaps technology can be really useful there.
Yeah, I'll double down on the comments on data. And I think it's really important to, as you're managing a population, to know what's happening with that population. We leverage third-party ADT feeds so that we know what's happening with our population. We know when to intervene. We work closely to get other connection points and data from our partners to know what's happening outside of our orbit. So I think those are really important because it's really those no one wants to be engaged with when they're feeling good, right? People want to be engaged with when they're at their lowest or they're scared or they had something that happened to them. They want to feel cared for and they want to feel that someone has been looking out for them. And so it's really knowing when those right moments occur and then using technology and that mix of human first, tech behind when it's a trusted moment versus tech first and human enabled when it's more of a sort of ongoing engagement that we leverage as we try to build those trusted relationships. Obviously, really important with a population that is a stigmatized condition. Many people aren't associating with that stigmatized condition at any given time. And so what needs they have and really being human first in how you engage, I think is another important piece.
And Seth, I'm curious from your perspective at Inbound, how are you guys thinking about technology in the hospital at home and step at home space?
Yeah, so similar to something Joe said, it's really, I think in my mind, critical that we get as far upstream as possible in terms of understanding our patients and also predicting ahead of time who is going to require earlier intervention and treatments. And so part of how we're approaching that is on the front end, doing a really good job understanding who our patients are and really risk stratifying them and bringing in factors about their home environment and social support, and then also incorporating biometrics and real-time data. And I think with that comes a challenge of you've got a lot of data, and so you really need to think through an approach to how do you optimize the signal to noise ratio and focus on the most important things. And for us, I think that's where the AI ML piece comes into place to both enable and optimize the analytics approach over time and ensure that we're really focusing on the right interventions at the right patients at the right time. And then I think the home environment also provides this really rich opportunity to engage patients and families. And so that's underpinned by technology that obviously can facilitate that in the most effective way. But I'd say it's not only about the synchronous interactions with patients and providers, but also how does that technology facilitate, going back to that team concept, a way to ensure that the team is coordinated around the care of that individual patient. And so that's an important way that we're developing and using our technology to enable clinical care.
Great. We are close on time, so I'll wrap up with maybe one more question. I'm curious your perspectives on all of this as we think about building companies in this space. There's discussion around what are the skill sets. We've talked a little bit about actuarial, we talked about finance and analytics. I'm curious from your perspectives, what was the most important hire for you all, maybe at your current company or even previously, as you thought about designing these models? And maybe Eleanor, Corbin, I'll pick on you first to talk about Eleanor.
Hopefully my co-panelists will appreciate this answer, but I think the first hire, I think any digital health company or any healthcare company that's delivering care or touching the member, it's really important to have a really strong clinical voice and clinical leader who can help shape that model. That's, I think, really important to any company that's touching patients. We talked about data. That's really important to be collecting so that you can serve up the value that you're providing early on. As you scale clinical operations, actuarial, those become more and more important, but I'll start with the clinical leads since I'm the only non-clinical, non-doc on this panel.
Love that. Joe, what would you say?
We're all clinical, Corbin. We're all caring for patients. I'm not going to say, so I'll skip the clinical side of things. I do think the data becomes key in value-based care, right? So understanding not just how you ingest it. We always think about data capture, integration, analysis, reporting, and then use, right? Because you got to get that whole chain really effective to help drive the foundations of what we're doing. So having a very sort of visionary, front-facing analytics and data human being come into the organization to help out. And I think we're seeing the fruits of that at Somatus, and it's great. So I think that was super, super critical.
Fantastic. And Seth, what would you say?
Yeah, I think Joe and Corbin hit important ones. I would also say having really good legal counsel, whether it's in-house or outside counsel that you can really trust, is important, because all of us are really trying to innovate and push the boundaries around how we can provide the best possible care at the lowest possible cost. And our healthcare system is very highly regulated, as everybody knows, and also very confusing and difficult to navigate, especially if you're doing new and disruptive things. So I think having counsel that obviously can provide guidance about where those guardrails are, but importantly, I think be a partner in working with business leaders around how to do this work effectively and ensure that it's done safely and compliant with all of the rules and regulations that govern the delivery of healthcare. So I always make best friends with my favorite lawyer.
I love that. Good counsel and a great way to wrap up this discussion. Thank you all three. I think we've run out of time and I'll have to pass it over to my partner, Dan Kimura, but this has been truly a delight and I really appreciate all three of your time. Thanks again. And Dan, I'll turn it over to you for our final discussion.
Thank you.
Thanks.
Thanks, Margaret. Really great discussion. I love that last one from Seth. Make sure you have a good lawyer if you're working in value-based care. Really excited to have our next set of panelists. We're doing the anchor leg of this session, and I know it'll be great. Veeral Desai, Chief Strategy Officer and Development Officer at Agilon Health. Emily Maxson, Chief Medical Officer at Aledade. I would argue the two leading physician enablement platforms. Veeral, I might start with you. You've had a really rich career in helping physicians transition over to value-based care, starting at Vantage Oncology, Maxson, and then now at Agilon. Tell us a little bit more about Agilon. What is a physician enablement business model? What do these groups need, and what resonates with them? What are they looking for?
Yeah, thanks, Dan, and thank you to the Flair team for bringing this panel together. As Dan said, quick background on me is I've spent my career focused in healthcare delivery and transformation, part of the leadership team that's helped to found Agilon Health. And Dan, to your question, what our model is and what we think physicians are looking for is a real partner to support the transition into a global risk model for the senior population. And what that model effectuates is deep alignment in a long-term model that is really focused around driving the alignment of outcomes. The core of our issue that we see with primary care is an unsustainable primary care model. And so ultimately, our model seeks to partner with the scale delivery organizations in the geography to really partner with that existing capacity and through a long-term orientation, really invest significantly ahead of the outcome. So one of the themes, and Will talked about this at the outset, while I agree we're past the early innings and that value is certainly mainstream, the investment mindset and the alignment mindset needs to be one that's really long-term to drive the level of transformation and ultimately the cost and quality and experiential outcomes that we're seeking to drive. And ultimately the problem we're trying to solve, and I think that resonates deeply with community-based physicians broadly, is that this is a model for them to realign the delivery system to move from seeing 30 patients a day and figuring out how to jam more patients into their schedule into one where they can reallocate, reinvest scarce clinical and care team capacity against the patients that need it most, do that through a singular patient experience. So we work on a multi-payer basis, and then being able to leverage data, technology, a lot of the attributes people talked about in this conversation to really bring that longitudinal approach to management of care and do that regardless of their underlying technology or practice management platform. And so we're really excited, and we'll talk more about it in the conversation around both the acceptance and adoption of these models, but really the proof points that have been developed now in very heterogeneous geographies with very heterogeneous physician organizations in terms of what is possible.
No, that's great, Veeral. And my understanding of your model is you certainly spend a lot of time with the physicians and the clinician practices, but you also spend a lot of time with the payer. How would you say that you split up that time?
Yeah, ultimately, you talk a lot about quadruple aim. I think this has to be, we started with our North Star as the primary care physician. They are from our perspective, the quarterback within the delivery system. We're effectuating global risk and integrating payment and delivery, with now enabling those physicians to be able to better care for their patients and be rewarded differently through global risk. The payers have to win in this model. And I think what we probably progressed the most significantly around over the last 7 years is that our payers are really winning, and that winning comes in the form of, one, there is a level of physician engagement, and I think Dr. Shrank would talk to this, that a payer can drive with the primary care physician. When you're operating on a multi-payer basis across their entire senior line of business in an integrated way, there's a deeper level of alignment and engagement between that model and ultimately a global risk model that allows you to be rewarded for the long-term outcomes that you're driving. And so there's, I think, a real benefit and highlight that comes to membership growth. That's really important to the payers. All the elements around quality, everything from accurate coding and documentation, but really taking groups and community-based physicians that don't have the infrastructure, that may not be as engaged, and taking them to 4.5 star plus performance. And then a real profit benefit, which is that they're de-risking huge elements of their business by virtue of pushing that risk down to providers that are now enabled with a capital base to go take on that risk.
Really great insights, Veeral. I hear this kind of phrase of alignment coming up time and time again, where both sides have to do well. And so how do you change the workflow in order for both sides, both the clinician practice as well as the payer, to see improvement in quality, outcomes, cost, and kind of membership retention and growth? So that makes a lot of sense. Emily, thrilled to have you on the panel today. Aledade has had an amazing run. You've been there primarily for the entire time. And I remember very vividly early on in Aledade's life kind of story, there was a big point around mission, allowing physician practices to remain independent. And I know that Aledade early on worked with smaller practices, now working with larger practices. Talk a little bit more about that journey, the role of kind of consolidation or the threat of consolidation on physician practices, wanting them to remain independent, and then Aledade's work and actually allowing that to occur.
Sure, thank you. And it's really delightful to share the panel stage with Veeral. I'll start with just my own journey coming from primarily academic medicine, large public health organizations, and really experiencing independent primary care for the first time. One of our practices that we went on the road in 2014 to visit was located in a log cabin. And each practice that we visited resembled the community that they were nestled in. And so it was just incredibly inspiring to learn from this network of doctors across the country, who many of whom grew up in the communities they serve, and they come back, they deliver the babies, they put the casts on the children, they hold hands in last moments. And so it's just an incredible community resource that we were very worried would be threatened, and we wanted to give them a mechanism of survival and sustenance. And we find that independent docs become independent for a reason. Many of them want to stay fiercely independent. They want to retain their autonomy and make their decisions so that they can continue to take amazing care of their communities. And the perils of running a small business in this age are such that some of them were threatened in their desire to remain independent. So we really prioritized helping them with the resources they need to transition into the next era of primary care. We have all of our practices with a foot in two canoes, one in fee-for-service and one in value-based care. And so they have to deal with things like negotiated fee schedules with the payer and remaining solvent and keeping their doors open while they try to innovate. And we think that it is our imperative to help them digest the amazing information you get from belonging to a value-based care contract and making it easy for them to know who to engage, when to engage them, and what to prioritize in their day. And also to have really instilled in their practices better team-based care models and more sustainable ways of practice, so that they can have the umbrella effect of amazing care over their non-contracted patients as well. So we took that mission to heart and recently became a public benefit corporation also, so that we could continue to make decisions based on that, which is amazing for primary care doctors across the country.
No, that's great, Emily. And again, I love the visualization of practicing medicine in a log cabin. And I love the metaphor of having a foot in each canoe, both fee-for-service and call it value-based care or kind of risk-based care with payers. Given that your provider base that you work with may be starting at different points, is there a minimum required set of infrastructure necessary in order to work with Aledade? But what's the sense of, do these practices have to do in order to be successful in your model?
Believe it or not, we once engaged a practice who is still on paper. So we are in 90 plus electronic health records, and we take pains financially and effort-wise to make sure there aren't barriers to entry. So we have also extended our engagement beyond independence towards mission-minded health system entities. And still the predominant base is our independent primary care doctors. We extend that in our minds through rural health centers and federally qualified health centers. And we, because all of our original team pretty much originated their careers in public health, we had Medicaid on the brain, underserved patients on the brain, and fundamentally believe that we're not succeeding in bringing value-based care to light if we're leaving our most vulnerable patients behind. So thinking a lot about how we empower federally qualified health centers and RHCs and value-based care too. So we've expanded and serve the onesie twosie doc shops as well as larger health systems at this point across, let's see, almost every state in the continental US. We've got 2 million lives and 1,500 practices. So they are pretty diverse across the country at this point.
No, that's great. And Emily, I'll stick with you on that point. It's a great segue. When we think about quote unquote lines of business or the beneficiary status of the populations you deal with, it sounds like primarily kind of Medicare Advantage, those populations in ACOs, but then also it does sound like Medicaid is an emerging kind of category that you're working with. Talk a little bit about the opportunities and the challenges in that space.
I wish it were a bigger part of our portfolio. And I think that the problem with managed Medicaid is that the results are incredibly mixed, and it's really hard to take total cost of care risk on the Medicaid population, in part because state by state modeling makes the carve in and carve outs really different, and because of the infrastructure required to care for these patients. and the fact that they often come in and out of contract eligibility. And it's really difficult to sustain an investment in a patient population that shifts with the sands of time. So I think that there are a lot of reasons it's really challenging to succeed in Medicaid, and we are trying. And I think that the successes we've seen, I'd probably point to the management of dual eligible patients in our health centers. Health centers are amazing at managing these dual eligible patients and at combining grants creatively to serve patients. I think that the biggest impact we can have is through the aid of artificial intelligence, really helping practices understand who might benefit the most from any given initiative. As long as we can train our artificial intelligence out of bias. We had, if you'll allow me a brief diversion, we had an interesting experience where we were trying to capture patients who would be most likely to pick up the phone and respond to engagement for an initiative. And if you take a look at that, what we find is that if you prioritize patients by likelihood of engagement, you're going to systematically exclude total classes of patients, different races of patients. And so we had to look for it proactively. We had to say, in order to not leave our Black and African American populations behind, we have to train bias out of the model and make sure that we are really keeping eyes wide open to making sure the right patients receive the right service for maximum benefit.
No, that's such a compelling example. I think everybody knows if you want to succeed in value-based care and in population health, you have to segment the population for appropriateness of high-cost interventions. But I think the point that you made is often one that you don't hear a lot about, is that sometimes when you segment, there may be implicit bias in how you segment. And so you have to understand the implications of your process there. Super fascinating. Veeral, similar set of questions for you. Talk a little bit, and I know agilon maybe has a different experience in the Medicaid space. Talk about the lines of business that you work with. Talk about this concept of kind of population health, kind of segmentation in caring for more complex patients. What sort of work is agilon doing there?
Sure, and fascinating to hear Emily's experiences and observations. Yeah, so our business has been built entirely around a senior focus. We started with Medicare Advantage. With the introduction of ACO REACH, we're now working with a significant percentage of our practices across an integrated full senior line of business. So highly senior centric within that. To Emily's comments, we also have a significant portion of our population that are dual eligible. And so that is a growing portion of our focus. And to your comments, Dan, around risk and risk stratification, a lot of the engine of what we have built is the ability to meet any practice where they are from a technology and data standpoint, working with 30 plus different health plans across the country to integrate that, to understand and to segment patients for appropriate clinical programs. So our focus clinically disproportionately has been around specific high-risk patient categories. So we have a significant focus around renal disease, ESRD, CKD 4 and 5, massively underserved population per the prior conversation with Dr. Kimura, impacts about 4 to 5% of our patients, huge levels of variability. And remember, we are entering markets where there is significant undermanagement. This is not California, this is not Florida, where there has been massive managed care penetration. This is the rest of the country and the log cabin where you have huge variability. And so that is incredibly prevalent from a renal disease standpoint. So this is also a place where we've looked at partnership models, vendor partnership models, subcapitated relationships, where we can create high integration with our primary care physicians as a prerequisite, but then be able to wrap around these adjunctive resources and technology, and ultimately really deep alignment around the outcomes we're trying to drive clinically and from a cost standpoint. And then there's been a number of areas where we have built alongside our partners capabilities in areas like end of life and palliative care, where to your question, Dan, some of these groups have made significant investments, not with particularly strong ROIs because they're not in a full rest structure until our partnership, but have real infrastructure around how do you manage that important end of life experience for patients and families and communities. And now we've been able to really codify that, accelerate that, and now port it across more of our 32 markets. And so really big opportunities. And I do go back to this point of, I think because we are still early in the adoption of global risk, and because even for markets like ours that are quote unquote mature, like Columbus, where we've grown from 20,000 lives to 70,000 lives, and there's tremendous clinical infrastructure, I think we are still very early in the opportunity around the level of innovation and how it takes hold consistently, attacking the variability. We look at it at the physician level down to the member level. The opportunity and variability is so significant. And so that is our opportunity to drive consistency around the quality experience we want for all patients. And within that resides significant waste and ultimately margin potential as you think about the business model.
Perfect. Veeral, you get the last word. Emily and Veeral, this has been so helpful. I wish we could spend more time, but we are at the limit here. I will now transition it back over to Margaret to close this out. Thank you so much.
Thanks, Dan. And thank you to all our panelists. Appreciate your time and really insightful perspectives. We've covered a lot of ground, but obviously there's a lot more to talk about and would love to continue the conversation. So please reach out, and we look forward to seeing you at our next session. Have a great day.